All right, welcome. In this session, we're going to dive deep and build a really solid glossary of cardiac rhythms. Think of this as a university-level electrophysiology lecture, so we're going to be precise and systematic, grounding everything in the heart's anatomy.
So here's our game plan. We're going to follow the electricity, just as it flows through the heart. We'll start with the most basic rule for how rhythms get their names. Then we'll work our way down, anatomically speaking, starting at the sinus node, moving to the atria, the AV junction, and then landing in the ventricles. And to wrap things up, we'll take a closer look at those little hiccups called premature beats.
Okay, let's get right to it. The single most important thing you need to lock into your brain is this. Every single cardiac rhythm gets its name from where it starts. It's all about the locus of origin. That specific spot where the electrical impulse kicks off, that's what defines everything.
And this is where it gets really interesting, because this simple rule explains a concept called AV dissociation. This is where the atria and the ventricles can actually beat to their own completely separate drums. So for example, imagine you have a complete AV block. That means no signals from the atria are getting through to the ventricles at all. In that case, the atria could be in, say, atrial fibrillation, total chaos up top. But since none of those crazy signals can get through, a backup pacemaker, maybe in the AV junction, has to wake up and start its own much slower escape rhythm just to keep the ventricles pumping. Two different rhythms, one heart. See? It all comes back to the locus of origin.
So, keeping that core principle in mind, let's start at the top, right where all normal heartbeats should begin, the sinoatrial node, or as you know it, the sinus node.
Okay, so any rhythm that starts in the sinus node is basically defined by its speed and its behavior. A normal sinus rhythm, that's your standard 50 to 100 beats per minute. If it drops below 50, we call that sinus bradycardia. You often see this during sleep or when vagal tone is high. Kicks up over 100, that's sinus tachycardia, and it's usually a normal response to something like exercise or stress. A key feature here is that it ramps up and down gradually. Then there's sinus arrhythmia, where the rate actually changes a bit with your breathing. And finally, there's a pretty rare one called sinus node reentrant tachycardia. This is caused by a little electrical loop, a reentry circuit, stuck inside the sinus node itself. And unlike regular sinus tach, this one causes really abrupt, sudden changes in heart rate.
And this right here gives you a perfect side-by-side look. On the left, that's sinus bradycardia. See how far apart those QRS complexes are? That's a slow heart rate. Now look to the right at the sinus tachycardia. The complexes are all packed together much, much faster. But here's the key thing to notice. In both of these strips, the shape of the P wave and the QRS complex looks exactly the same. That's our big clue that the origin is still the sinus node. All right, let's move down a level into the atria. The rhythms that start here come from one of two places, either an ectopic focus, which is just a spot that's not the sinus node firing off, or from some kind of messed up re-entry pathway inside the atrial muscle itself. Atrial flutter is just a textbook example of what we call a macro re-entrant arrhythmia. What's happening is you have this one big organized electrical loop just going around and around and around, depolarizing the atria at a ridiculously high rate. Now the AV node down below, it's like a bouncer at a club. It can't let everyone in at once, so it blocks some of those impulses. Most of the time you get what's called a 2-to-1 conduction, meaning for every 2 of those flutter waves, only 1 actually gets through to the ventricles to create a heartbeat. And here's the classic picture of it. This is what we call pathognomonic, meaning if you see this, you know it's atrial flutter. Just look at the baseline. In between those sharp QRS spikes, you can see it clear as day, that perfect sawtooth pattern. Those are the flutter waves. That visual is the absolute, undeniable hallmark of this rhythm. Now, if atrial flutter is organized, atrial fibrillation is, well, it's pure electrical chaos. Instead of one big loop, you have all these tiny multiple electrical wavelets crashing into each other all over the atria. The result? The atria don't really contract effectively. They just quiver. And all those chaotic signals bombard the AV node, which lets them through randomly. This creates a ventricular response that's famously irregularly irregular.
And this strip shows you exactly what that chaos looks like on paper. Look for two things. First, can you find any consistent P waves? Nope. The baseline is just this messy fibrillatory wave. Second, try measuring the distance between any two of the QRS complexes. Go ahead. You'll find that every single one of them is different. That is the very definition of an irregularly irregular rhythm.
So, with all this potential for organized chaos, or just plain chaos bombarding it from above, the next stop on our tour becomes incredibly important, the atrioventricular junction, or the AV junction. This area is like the central gatekeeper between the upper and lower chambers of the heart. But it's not just a gatekeeper, it can also act as a backup pacemaker or even become part of the problem in certain fast heart rhythms. Okay, this brings us to a really important clinical term, supraventricular tachycardia, or SVT. You have to understand that SVT isn't a specific diagnosis of a mechanism, it's more of a generic label. We use it when we see a fast, narrow complex rhythm on an ECG, but we can't tell for sure exactly what's causing it. It could be a few different things, but the most common culprits are AVNRT and AVRT. To really know for sure, you'd often need to do a more invasive study with catheters inside the heart.
So let's break down those two main players. In AV nodal reentrant tachycardia, that's AVNRT, the whole short circuit, the whole reentry loop, is tiny and contained completely within the AV node itself. But in AV reentrant tachycardia, or AVRT, the circuit is bigger. The impulse travels down the normal way, through the AV node, we call that anterograde, but then it finds a shortcut, an extra wire called an accessory pathway, to travel back up to the atria, that's retrograde, and start the whole loop all over again.
And this slide really highlights the problem we face in the clinic. If you look at these 4 strips, they all show a fast, regular, narrow beat tachycardia. But their underlying causes, whether it's AVNRT, AVRT, or something else, are totally different. On the surface ECG, though, they can look identical, and that is exactly why we so often use that umbrella term, SVT. Okay, now we head downstairs into the ventricles. And we have to be serious here, because rhythms that start in the ventricles are often the most dangerous. They have the potential to cause a complete collapse of circulation and even sudden death, so recognizing them immediately is absolutely critical. Ventricular tachycardia, or VT, is basically a fast rhythm that starts from a rogue spot or a reentrant circuit down in the ventricles. We're talking rates of about 130 to 220 beats per minute. And because the signal starts in the ventricle and spreads through the muscle in a really abnormal way, the QRS complex it creates is characteristically wide. Here we have a perfect example of what's called monomorphic ventricular tachycardia. Monomorphic just means one shape. So look for 3 things here: a fast rate, a regular rhythm, and QRS complexes that are wide and, crucially, look exactly the same beat after beat after beat. That uniform shape tells us there's a single, stable spot that's firing off and driving the whole rhythm. Now, it is so important to be able to tell the difference between 2 types of VT where the shape does change. First, you have torsades de points. This is a very specific thing. It's a fast, polymorphic, or multi-shaped VT, but its defining characteristic is that it's always linked to a long QT interval on the patient's baseline ECG. If you see a similar-looking twisting rhythm, but the QT interval is normal, you don't call it torsades. You just call it polymorphic VT. And making that distinction is life or death, because the treatments are completely different. This strip is just a beautiful and terrifying example of what twisting of the points actually means. Just follow the peaks of the QRS complexes with your eye. You can see the whole electrical axis just slowly rotating, twisting around that flat baseline. This wild, undulating look is the one thing that screams torsade de points. And this strip shows the final tragic progression of a cardiac arrest. On the left, that's ventricular fibrillation. It's not a rhythm. It's just complete electrical anarchy in the ventricles. There's no organized contraction, which means no blood is being pumped. If you don't shock this immediately, it will inevitably degrade into what you see on the right: asystole, a flat line, the total absence of any electrical activity. All right, to finish up our glossary, let's talk about premature beats. Now, these aren't sustained rhythms themselves. Instead, think of them as isolated blips, single electrical events that interrupt whatever the baseline rhythm is. They happen when some ectopic spot decides to fire off early, before it's supposed to.
And how do we classify them? Well, we go right back to our number 1 rule. The name comes from the origin. If a premature beat starts in the atrium, it's an atrial premature beat, an APB. If it's from the AV junction, it's a junctional premature beat, or JPB. And if it comes from the ventricle, it's a ventricular premature beat, or VPB. And that brings us to a super important rule. If you see 3 or more of these VPBs in a row, that's it. By definition, that's a run of ventricular tachycardia.
So let's wrap this all up with a question that ties everything we've talked about together. If our big rule is that every rhythm is defined by where it starts, how does that help us with a single, isolated premature beat? Think about it. How does the specific shape of that one beat, its morphology on the ECG, act like a map, letting you pinpoint exactly where in the atrium, the junction, or the ventricle that little troublemaker came from?